hello.
Hello. Hello, everyone.
Hello. All right. It's so nice to meet you.
Thank you.
So, everyone, Dr. Sylvia came in the very last minute because they just released their paper on
Yeah.
allopurinol just last week. So, we're so fortunate that you're here and able to chat with us a little bit. Um,
And I am the biochemist of the study, so I'm not the clinician.
yes, yes. Understood. So, no clinical questions, only biochemical questions.
Yeah.
Can you talk a little bit about how the study was put together, how many folks you had enrolled, and sort of what you saw, and I guess also how you dosed them. Just give us the overview of how the study was.
Um, it's starting from an hypothesis that Irene Sebalost, the biologist who initiated this work, that was in 2016, I guess, that inhibiting the first steps of de novo synthesis of perinucleotide should be able to reduce the succinylpurines and help reducing ADSL symptoms. And she, from 2016, she made a proposal for funding this study. So the study, she had the funding, but she had many health issues, so she retired. And the study starts in in October, just before COVID.
Mm-hmm.
2019, October 2019, and until October 2021.
Okay, so it was,
So, yeah, it lasts longer than it should have been because of COVID.
yes.
And I was the biochemist of the study, so I was in charge of Sanquer and S adenosine analysis in urine,
Mm.
but we can do it in plasma also. And even we can do it in amniotic fluids because we did it last week in the lab because a pregnant woman had a fetus with very cerebral abnormalities and the that and the I don't remember the name, and they do genetics on it, and they found mutations, variants, but with unknown signification. So we performed analysis and we with control fluid, amniotic fluids, and we show that uh, succinylpurines in this fluid was really high, much higher than normal amniotic fluids. So thanks, Nicole, for your introduction. So uh, I have some issues with, well, I'm going to present you the results of a study that had been recently published on treatment of ADSL deficiency with allopurinol. So ADSL deficiency is a rare autosomal recessive disorder of purine metabolism. The first case was described in 1984, and data from approximately 100 patients have been published internationally, mainly in Europe and the Mediterranean region. But the incidence of the disease remains unknown because we think it is underdiagnosed. Um, ADSL deficiency covers a continuous clinical spectrum with three main forms: the fatal neonatal form, the type 1 deficiency, which is the severe form, and the type 2 deficiency, which is a moderate form. For the fatal neonatal form, the symptoms appears the first days of life as encephalopathy, loss of spontaneous movements, respiratory distress, and drug-resistant seizures that lead to death in the first weeks of life. Symptoms of type 1 deficiency appears within the first year of life, has severe psychomotor delay and autistic traits, early onset epilepsy, microcephaly, and strabismus. Type 2 deficiency, the symptoms appears around 2 years old, as moderate psychomotor delay, delayed language, um, let me see, yeah. Delayed language acquisition, and later onset epilepsy. ADSL is an enzyme involved in purine metabolism. It is a bifunctional enzyme composed of 484 amino acids that catalyzes the conversion of Sanquer for succinyl aminoimidazole carboxamine ribotide to ACAR and the conversion of succinyl AMP to AMP. ADSL deficiency leads to an accumulation in biological fluids of the enzyme's two dephosphorylate substrates, Sanquer with a little r for succinyl aminoimidazole riboside and succinyl adenosine or SADO. The underlying abnormality is associated with mutations in the ADSL gene located on chromosome 22. No strict correlation between genotype and phenotype has been identified so far, and the clinical severity of the disease correlates with residual enzyme activity and mutated enzyme stability. The diagnosis of ADSL deficiency is based on 4 elements: the clinical, imaging, biochemical test, and genetics. The clinical symptoms that warrant screening for the disease are hypotonia and acquired microcephaly, unexplained psychomotor delay, unexplained developmental delay, and unexplained seizures. Brain imaging shows abnormality of the white matter, cerebral cortex atrophy, delayed myelination, and lissencephaly. The definitive diagnosis requires the detection of the two succinylpurine, Sanquer and SADO, in extracellular fluids and or the mutations in the ADSL gene. The biochemical diagnosis of ADSL deficiency is currently performed using liquid chromatography coupled with tandem mass chromatography, with the use of internal standards corresponding to stable isotopes of Sanquer and SADO, and special thanks to Dr. Marie Zikanova, who provides us with these compounds. Routine testing is performed on urine samples with the following reference value. Value should be lower than 1 micromole per millimole of creatinine for Sanquer and under 7 micromole per millimole of creatinine for SADO. Hypotheses explaining the pathogenesis are based either on the toxicity of succinylpurine or a deficiency in purine nucleotide production. Regarding the hypothesis of succinylpurine toxicity, it has been clearly shown that the SADO over Sanquer ratio in cerebral spinal fluid correlates with clinical severity. It is far below 1 in the neonatal fatal form, close to 1 in the severe form, and higher than 2 in the moderate form. This suggests that Sanquer is the neurotoxic compound and that SADO may have protective effects. This is confirmed by experimental data showing that infusion of Sanquer into the brains of rats induces significant neuronal damage. The hypothesis of a purine nucleotide production deficit is not supported, as normal nucleotide concentration have been measured in various tissues of patients with ADSL deficiency. These results suggest that ADSL activity, although greatly reduced, does not limit nucleotide synthesis, and that the purine salvage pathway involving the enzyme HPRT for hypoxanthine guanine phosphorybosyltransferase transferase, in green here, APRT for adenine phosphorybosyltransferase transferase in pink here, and adenosine kinase in blue here, would compensate for the deficiency. No treatment trials for ADSL deficiency have proven to be effective so far. Trials of treatment with uridine and D-ribose, which are thought to increase PRPP production and nucleotide synthesis, have not shown efficacy. Trials of treatment with S-adenosine methionine, which is the donor of adenosine, a nucleotide precursor, have also not shown efficacy. So mainly, treatment consists in epilepsy management in order to reduce the frequency and intensity of seizures, and may require several types of approaches, such as the ketogenic diet and anti-epileptic drugs. However, resistance to this treatment is very common. So in this context, I told you earlier, Irene Ceballos hypothesized that inhibiting the first step in de novo purine synthesis could lead to a reduction in the amount of succinylpurines produced, particularly Sanquer, which is known to be the neurotoxic compound. Allopurinol is a drug commonly used as a xanthine oxidase inhibitor for XO here in this scheme. This drug is approved for the treatment of primary or secondary symptomatic hyperuricemia, gut and uric acid stones. But also, allopurinol is a structural analog of hypoxanthine and therefore a substrate for HPR2 and produces ribonucleotides of allopurinol that will inhibit de novo purine synthesis by inhibiting PRPP amidotransferase activity. Given the low toxicity of allopurinol, we decided to evaluate the efficacy of this drug on patients with ADSL deficiency. So a phase 2 prospective non-comparative trial was initiated to assess the efficacy of allopurinol treatment over 12 months on adaptive and cognitive functioning in patients with ADSL deficiency. Standardized psychiatric assessments were performed at baseline after 6 months and 12 months after treatment initiation. Eligible participants included children over 18 months and adults with confirmed ADSL deficiency through urinary succinylpurine testing. The study aimed to treat participants with allopurinol orally for 12 months in 1 to 3 doses, not exceeding 400 mg per day for children and 900 mg per day for adults. For patients with renal impairment, the dosage was adjusted according to renal function with a maximum of 300 mg per day throughout the study. So 8 patients, patients 2 to patient 9, with ADSL deficiency were enrolled in the trial. So from October 2019 to July 2021, consisting of 4 children, patient 4, 5, 6, and 7, and 4 young adults. The age range from 5 years and 8 for the youngest to almost 25 years old for the oldest. All patients exhibited moderate to severe global developmental disabilities since diagnosis, moderate for patient 4, 5, and 6, and severe for patients 2, 3, 7, 8, and 9. 4 patients presented pre-existing epilepsy diagnosis, patient 2, 3, 8, and 9, and autistic features were noted in 5 patients, patient 2, 5, 5, 6, 8, and 9. The succinate purine concentration in urine was far greater than 1 micromole per millimole of creatinine for Sanquer, as you can see here, and far greater than 7 for SADO, as you can see here. 6 patients had a SADO over Sanquer ratio lower than 1.8, indicating a severe infantile form of ADSL deficiency, while patient 5 and 7, in pink here, exhibited ratios greater than 2, corresponding to a milder form of the disorder. Urinary xanthine levels were quantified to monitor allopurinol compliance. An increase in xanthine concentrations of at least tenfold was observed in nearly all patients except for patient 8 and patient 9, during the first 3 months for patient 9. This means that patient 8 and patient 9 exhibited moderate compliances, also assessed through family interviews and pill counts. Patient 8 did not reach the full allopurinol dosage, while patient 9 received 20 mg per kilo per day from the 6 months. Patient 8 and 9 were brother and sister, and the father did not accept to give the full dosage of allopurinol. Adverse events of allopurinol were assessed at each visit. Crystaluria did not show the presence of xanthine crystals, and renal ultrasound did not show any significant abnormalities throughout the study. So here we can see the biological response of allopurinol treatment. These 4 patients, patient 4, 5, 7, and 9, exhibited a reduction in Sanquer concentration throughout the study and an increase in the SADO over Sanquer ratio, reached values over 1.8 at the end of the study. The neuropsychological assessment was performed at 3 periods of time, at inclusion and after 6 months and 12 months after treatment. The primary outcome assessed the improvement in adaptive and cognitive functioning over 12 months using the Vineland Adaptive Behavior Scale, version second edition, VAPS2, which evaluates communication, motor skills, socialization, and daily living skills for both children and adults. An aberrant behavior checklist was also performed using the aberrant behavior checklist, or ABC. An aberrant behavior evaluation was also performed. So here are shown the clinical response obtained using the Vineland 2 scoring at M0, M6, and M12. This scoring yields 3 subscale scores: communication, daily living skills, and social skills. And a composite score is calculated at the end, with higher scores indicating improved adaptive functioning. The clinical examination remained stable for all patients with no new neurological signs. The total composite score showed clinical improvement in 4 patients, patient 4, patient 5, patient 7, and patient 9. All subdomains were improved in these 4 patients. Patient 4, 5, and 7 exhibited progressive improvement from inclusion to the end of the study, while patient 9 improved from M6, coinciding with better treatment compliance. Patient 7 demonstrated the most consistent linear progression. Here are shown the results obtained from the aberrant behavior checklist, ABC, at M0, M6, and M12. So the ABC includes 58 items across subscales for irritability, social withdrawal, stereotypic behavior, hyperactivity, and inappropriate speech, with scores ranging from 0, when there is no problem, to 4 for severe problem. Improvements in hyperactivity scores were noted between M0 and M12 in 4 patients. That was patient 3, you can see it here, patient 4, patient 5, and patient 7. Additionally, irritability decreased in patient 2, patient 7, and patient 9. Patient 2 also showed reduced lethargy, while patient 5 experienced an increase in lethargy and irritability, coinciding with the diagnosis and treatment of epilepsy. The variable stereotypic behaviors and inappropriate speech did not show any tangible changes. So our finding indicates a positive clinical and biological response to allopurinol in patients 4, 5, 7, and 9, who were the youngest patients and the less cognitively impaired patients. This was particularly true for patient 7, who made substantial advancements in psychomotor development. The youngest 4 patients improved their scores mainly on the communication and social skills score of the Violence scale and on the hyperactivity score of the ABC. The reduction in hyperactivity may have facilitated better focus and interaction. Clinical improvement correlated with significant reduction in urinary cycle levels and increased SADO over cycle ratios, aligning with values seen in less severely affected patients. In contrast, patients 3 and 6, who did not show improvement in the total composite score on the VAPS-2 with allopurinol treatment, exhibited only slight reduction in urinary cycle levels and modest increases in the SADO over cycle ratio, remaining well below 1.8, indicative of the most severely affected patients. Patient 2 and patient 8 demonstrated neither clinical improvement nor changes in succinylpurine after allopurinol treatment, with SADO over cycle ratios remaining below 1.8 at both inclusion and the study's end. So, from a biological perspective, these studies show a relationship between decreased cycle levels, increased SADO over cycle ratio, and clinical improvement after treatment with allopurinol, and more pronounced effect in patients with less severe disease at baseline. From a neuropsychological perspective, our study shows a positive effect on the overall level of adaptive behavior, a psychomotor regulation, a link between reduced agitation and increased social skills and independence, and more pronounced effect in younger patients. So, in conclusion, our study showed the effectiveness of allopurinol treatment for ADSL deficiency. Allopurinol is a well-known and inexpensive drug. Our findings support that early treatment is likely beneficial in patients with ADSL deficiency. This finding may open the way to newborn screening. In the absence of alternative therapies, allopurinol may be considered a viable treatment option. Thank you very much for your attention.
So my question was, and you may not know the answer, I hope you do. Do you know who performed the behavioral screening, the ABC test? Do you know, was it the same person performing that test time to time?
I think 2 persons did that. That was Beranger and Michaela, I
Oh,
think.
okay. Oh, that's wonderful. Yeah, I've one of the
And
things.
mostly Beranger.
Oh, okay. Okay. Yes, I did communicate with her.
Mm.
So yeah, one of the things that we've noticed is behavioral screening for our kids is it's very difficult to do. And we're actually, Rare Birds Foundation is working on some new screening techniques, but because the children are so or should I say,
Yeah,
patients are so up and down. Those behavioral screens can be very difficult to get to just hit just right. So I'm at least glad to hear that it was the same person performing them because the person performing them makes such a big difference in the overall screening.
but
Does oh,
Beranger told me that the most effective effect was the reduced agitation, reduced hyperactivity, and the patients were able to focus, and
that's
that
what
was the main skill she noticed.
okay.
Yeah.
What would you say? So you say it's not as effective for older patients, more effective for younger. Is there a cutoff at what age?
It's younger and less severely impaired.
Mhm.
The ratio, with the highest ratio.
Okay. Yes. So the highest ratio saw the best.
But we don't know if, because when the diagnosis is done, we have the level, the ratio. We know the ratio, but we don't perform succinyl analysis afterwards. So we don't know how they, if they increase or if they stay stable. We don't know. We don't know.
Yes. That test, the sidecar test, is actually not available in the United States either. So I know that, and other places as well. I assume we don't even have that information available to us. But that's very good to know. So you and your patients, let's see, the adult patients, the oldest was 28.
The other 25.
25, I'm sorry. So are you considering an older patient, 18 and older?
Yeah,
Yeah.
18 and on. Yeah.
Okay. Excellent. Let's see here. Okay. Someone has asked, so what's next in your study? My son, for example, is 4 years old and has a more mild form of ADSL. Do you now, she's asking, do you suspect that in the future they could benefit from allopurinol and were there any side effects? So, Dr. Sylvia can't give any clinical advice.
No, but when the enrollment of patients within this study was over, two brothers were diagnosed, two young brothers were diagnosed, and we gave them allopurinol as a compensate, as voilà, and they have good biological and clinical response.
Hmm,
They are under allopurinol for now 2 years and a half, and for the
good.
moment, it's good.
I was going to ask that too. How many sibling groups or sibling pairs did you have in the study? You had at least one that you spoke of already.
Yeah, yeah. We had one sister, but the two brothers were not enrolled in the study.
Okay.
Parents didn't want.
Uh-huh.
That's it.
Oh,
And maybe two other sisters.
okay. Okay. So two sibling pairs.
Yeah.
It's very interesting. And Denise, I think that what Sylvia was saying was there were no reported side effects. So you didn't see any
No.
increased xanthine crystals, no other renal issues or liver issues. I will tell you personally, this is personal. This is not medical advice. I'm going to probably say that 15 times, but that's okay. My children were on allopurinol for 2.5 years when they
Hmm.
were younger. We discontinued because we weren't sure. And we got to a level where we were giving so many anti-seizure medications that we decided just to draw down on medications that we weren't sure about. But my children were on that for many years. And I think Flora was less than 1 year old when we put her on allopurinol. Um, so I never noticed anything, and we were following them pretty closely with, follow-up testing to check their liver and all those enzymes and everything. I did not see any adverse effects from the allopurinol personally either. So my personal experience is also corroborating this study. We have a parent who has said, sorry, let me go back. So she's had to leave the meeting. She put one of her sons on a daily dose of 400 milligrams of allopurinol after she heard of this study, but he is now 33. She's saying she has seen an improvement in his alertness and interactions with us, but do not know if allopurinol is the catalyst. And of course, without what I really like about this study so much, Sylvia, is you take behavioral aspects and you match them with the biochemical things that you're seeing. So you have these 2 points of data. Um, Again, we don't have access to that kind of testing, the Sanquer testing here in the US. So
Mm.
this mother, Melanie, wouldn't even really be able to test biochemically, but it's good that she's seeing some good improvements. And she says, thank you for your work.
Thank
Um,
you.
yeah, and a lot of the families are saying they'll be sending this study on to their doctor, which is exactly what we want. We want doctors to have this information as well. So,
And I think that we have to consider the issue of newborn screening because the earliest we diagnose the babies and the earliest we treat them,
the best outcome.
the benefits will be improved.
Yes, I absolutely agree. Um, Melanie was also asking, I'm just going to answer her question, even though she's not here, in case she comes back and watches it through. She's saying, how big a dose do you think is generally safe? In the study, you said, was it 900 milligrams was the maximum dose for adults per day?
Yeah,
Okay,
maximum dose was 20 milligram per kilo per day.
20 milligram
Per
per
kilo,
kilo per day.
yeah.
And some of the patients were getting a single dose or they were getting 3 doses throughout. I think there was
I don't know. I don't know. I think it's mainly two doses, one morning, one in evening.
yeah, 900 milligrams is a pretty high dose to know.
But allopurinol is largely prescribed in many patients, and for over that 40 years now. So
Yes, and it's a treatment for gout. Yes. Yeah.
yeah,
Yeah.
it is well known.
hmm Maya is asking, you mentioned S-Ado may have a protective effect. Could you talk about that
Mhm.
a little bit more?
It's because of the ratio.
Mm.
So we know that Sanquer is the neurotoxic compound, and because the ratio increase, so uh, Sanquer decrease, but SADO increase. So we suppose that it's a hypothesis that SADO has beneficial effect, but we are not sure. It has
Yes.
to be proven.
I've heard other people hypothesize the same, that
Yeah.
SADO has that protective effect. So that is certainly something that seems to need a little bit more research. Absolutely, I think a good thing to do is to take this study to a doctor because the
Mm.
study has the dosing that you used in the study in it, and that can help guide people to come to that
Yeah.
number.
Yeah. Everything is described. So
Yes, yeah. I also want to, this is, I'm going to say thank you to Dr. James Nurse, who he is, he does social media for the Journal of Inherited Metabolic Disorders, and he alerted me to the fact, Dr. Sylvia, that you all had released this paper on the day it came out, which was the only way that I heard about it. And so I just want to give a thank you to the folks that are contributing to make sure I get all of the most up-to-date information.
I have question if I can.
Yes.
My is Ghana. I would like to ask if you use a reference value for specific age, because a reference value for Sanquer and also for SADO are age specific, and especially with the younger children, the normal values for Sanquer and SADO are higher than for older. And your study was 5 years, so I suppose that in younger children, the values, I don't know which age was the first age for the study. Do you understand me? Because we know that Sanquer is different in normal, in controls for age 2 and different for age, for some, I don't know, 3 months, and different for 5 years old children, or just this. If you considered this difference.
I'm sorry, I didn't understand the question.
Are you saying, Dr. Zikanova, that the ratios change across the life cycle?
I cannot say that ratio change, but the values, specific values change, and not just in the ADSL deficiency, but also in control samples in a healthy child.
Mm.
In healthy,
so
you see, you say that in healthy patients, the ratio, the values change.
Yeah, I'm sure we know it.
As in patients with ADSL deficiency?
I don't know, because we don't have alive children, older children with ADSL deficiency. We are able to measure it, but we don't know how it changes. I am sure that it will change, probably. I'm also sure that Sanquer in adults will be lower than in children with ADSL deficiency.
Yeah.
But I cannot prove it. But I know that in control samples or in healthy children, these metabolites are higher than in adults.
I assume that the value, the succinylpurines values and the ratio change with time in ADSL patients, but I don't know exactly, because we haven't made the analysis, so we don't know exactly if it is the case. But we assume that it is the case.
Yeah.
Because in these 8 patients, the youngest were the less severely affected, as indicated by the SADO over Sanquer ratio. And the oldest were the more severely impaired. But I think that when they were younger, the ratio was higher. But we don't know exactly, because we didn't do the analysis. So I think we have to follow over time these patients.
I'm not sure if we can talk about SADO-Sanquer ratio in urine, because I know that it correlates in cerebrospinal fluid, but not the urine. It's changed. The ratio changed in urine in one patient. So I think that that just the ratio, SADO-Sanquer ratio in cerebrospinal fluid is valuable. But it's not possible to do. But we can speak about SADO and Sanquer levels. So yeah, it's changed.
For this study, we did blood analysis as well as urine analysis, and the results were similar in these two matrices.
Yeah. I know. Okay, thank you.
That's wonderful. Okay. Thank you so much for that wonderful presentation and those great questions.
Bye-bye.
Bye-bye.